Perfect.
When I didn't realise.
You said me
All right, I think the silence means we can start. Looks like everyone's come. All right. Hello, everyone. My name is Adam Cammerman. I'm an anaesthetist at Charlie's. Come on in, Mark. Thank you all for coming tonight. I'd first like to begin by acknowledging the traditional custodians of the land on which we meet today. I'd also like to pay my respects to elders past, present and emerging. So thank you all for coming to the biannual WA Regional Anaesthesia Journal Club meeting. It's nice again to see, a mix of public, private, consultants, trainees, and thank you also to the APS nursing staff that have come from both the public and private hospitals. It's nice to have you guys all here. You play an active part in caring for our patients, and it's nice to be able to collaborate and to have a chat with you guys as well tonight, so thanks for coming. Without our sponsors tonight, we wouldn't be able to run this event. So thank you to Melissa and Ali from GE Healthcare. We'll be using your ultrasound with Divya for her scanning tonight. To Michelle and Catherine from ICU Medical, to Katie and Kiali from Duke Medical, and to Scott from Medtronic. Unfortunately, Lydia from Avant is unwell tonight and she couldn't make it. So, just some quick housekeeping. If you haven't already scanned the QR code, most importantly, to log attendance and get your certificate, there are a few just outside the auditorium and just inside as you walk out, so please do that. Toilets are just outside and to the right, and I hope that you've all managed to eat and drink something. Feel free to stick around after the talk for a quick catch-up if you like. So tonight we have three fantastic speakers to educate us on spinal catheters, on ultrasound guided neuroaxial blocks, and on nerve stimulators for regional anaesthesia use. We will aim for all three speakers to follow on one after the other, and we'll just leave time for questions at the end of the talk. So if you guys can just save your questions for the end. We'll have some roaming microphones for a bit of a Q&A session. So this is, I think, the 5th Journal Club meeting that we've been running over the last 3 years. Please, if anyone has any ideas for talks that they want to hear or give, we're always looking for more ideas. The next one that's coming up is in October. And we've already got a couple lined up. One of those will be a comparison of interscaling catheters, saline versus ropivacaine, looking at the outcome of that. And another one will be 1 milligram per kilogram IV dexamethasone intra-op for total knee replacements, looking at the outcomes of that, which has recently been given. Very, very large dose. All the talks will be recorded and will appear both as a summary in the WASORA newsletter and also on the WASORA website afterwards. So just before we start and we introduce the first speaker, Dr. Chris Mitchell just wants to have a quick word quick public announcement. So we will start shortly.
Thanks, Adam, and thanks for running such a good night all the time. It is a bit of public announcement. I've represented WA on the Regional Anaesthesia Special Interest Group for a few years now. It's just been renamed Australian New Zealand Regional Anaesthesia Group, but I'm looking at standing down from being on that. And when I suggested that I nominate someone to them who'd be good to take over from me, they suggested it might be better that we use a bit more democratic system and open it to the floor. So if anyone's interested in representing WA over in our special interest group, it's a nice thing to be involved. It gets you involved with all the different conferences. The biggest ownership that can occur with it is that any of the national conferences that are here, you'd normally be the go-to person to try and help organise the talks and the regional workshops and everything else that would occur on those occasions. And very long term, maybe in about 7 years, we might have another WASORA, which is the major national meeting back here in Perth, and you would then be lining yourself up a little bit to help organise that. But it's a really good group to be involved with, and if you'd like to be further involved in regional anaesthesia nationally, just please give me a call or an email and we'll have a chat. Thanks.
Thanks, Chris. So our first speaker is Dr. Joel Krause. Joel is a new consultant, having completed his regional fellowship at Charlie's, and he also completed a SIM fellowship in Darwin Hospital. Obviously has a keen interest in regional anaesthesia, and tonight he'll be talking about spinal catheters. So please welcome Joel.
Thanks, Adam. Hi, everybody. Thanks for coming. You just hit that one. Great. All right, there we go. Very good. All right, thank you very much, Adam, for inviting me to talk today. My name's Joel, and today I'll be talking about continuous spinal anaesthesia. So my interest in this topic sort of started from a case that I had when I was a fellow here at the start of last year. And I was in the ortho trauma theatre, and I was with a consultant, and the first case of the day, 83-year-old with a neck of femur fracture. He had a witness fall, no head strike or loss of consciousness. But he had a lot of comorbidities. He was very frail. The main issues were base of tongue squamous cell carcinoma, which was palliative, deemed non-operable. He was on immunotherapy but had an advanced airway cancer. He'd had COVID 3 weeks earlier. He had atrial fibrillation, no cardiology investigations, but had a very poor functional status, so could only manage 10 metres with a four-wheel walker. And he had severe peripheral vascular disease. He also had mild to moderate dementia. So as with any of you guys who do, regular ortho trauma, eventually you come across cases where doesn't really feel like there's a good option, and that's how it felt in this case, which filled us all with joy. The options that I was thinking in my head was single shot spinal, that's good, you can avoid the airway, but if for whatever reason you needed to convert to a general anaesthesia, that wouldn't be ideal going into that territory with a palliative airway cancer. General anaesthetic, again, you're going to have to deal with the airway. Combined spinal epidural, that's good because you can prolong the anaesthetic time. So if they do run into troubles and you need to prolong the regional, you could do that, or not proceed with surgery, which we would, rarely choose. But continuous spinal anaesthesia, it wasn't an option that I had come across before. I'd heard of the rare cases of people using intrathecal catheters, for example, if there'd been an accidental dural puncture in an obstetric setting, but I'd not come across a case before where it was used deliberately, and I thought, actually it makes a lot of sense, but my first reaction to it as a suggestion was there must be a good reason why we don't do it, so I decided to do a deep dive on it. So I'll touch on why you'd do it, why you wouldn't do it, compare it a little bit to the other techniques, talk about how to do it, and we'll talk a little bit about the experience at Charlie's, which is an institution that has a lot of experience with this technique. So most of the evidence around it is moderate size observational studies, which is reasonable to get complication rates from the technique, small unblinded single centre RCTs to compare it with different techniques for given procedures, several excellent review articles, and there's not been a meta-analysis or a Cochrane review on it. So why would you use it? The biggest reasons to use it are excellent control of segmental spread of spinal anaesthesia. So you don't have to commit to one dose, give that dose, and then what you get is what you get. You can very carefully titrate it. Excellent and reliable prolongation of anaesthesia, so you can really use it indefinitely for surgical anaesthesia. Decreased risk of cardiovascular side effects, which I'll touch on in a moment, and it can also be used for post-operative analgesia on the ward in complex surgical cases. So why wouldn't you use it? Post-dural puncture headache is one reason that you might want to not use it, although, and I'm sure that we've all gone through training in a career trying to not puncture the dura with our 2E needle when we're doing a labour epidural, and the reason for that obviously is you don't want to cause a post-dural puncture headache, which occurs in 41% of the obstetric population. Having said that though, if it's a non-obstetric population above the age of 40, the incidence of it being a complication is about 2.8%, and if they're above 65, the incidence is lower, more in the range of 1 to 2%. What about neurological complications? So again, it feels, you might think that it's got a very high rate of neurological complications, but actually it's quite low. Transient neurological complications like paresthesia that are lasting longer than the duration expected from a spinal anaesthetic is about 0.4%, so maybe 1 in 200 or thereabouts. Permanent neurological complications are fortunately very rare, and I'll touch on a couple cases in a moment, and efficiency of the technique. It takes a little bit longer than a single shot spinal. So why is it so rarely used? So this is a little bit of a walk down history lane. Cauda equina syndrome, I'll just go over it a little bit. Basically, there used to be a lot of enthusiasm for spinal microcatheters in the late 80s and early 90s in America, and there was a series of 7 case reports of cauda equina syndrome from the technique. So the FDA withdrew the catheters from the market, and basically the technique was left aside since then. And that caused a decrease in the enthusiasm for the technique globally, but I'll just touch on those cases. So cauda equina is low back pain, saddle area sensory disturbance, lower limb neurological deficit, and bowel and bladder dysfunction. And the 7 cases are outlined here. You can see the ages, you can see what they were using as well. So 5LH is 5% hyperbaric lignocaine, 1% hyperbaric tetracaine is the other one. So all of them were either high concentration lignocaine or tetracaine, which is more potent than bupivacaine. They were used in high doses and they were all hyperbaric. And what the theory as to why this happened is, if you can imagine that you've thread your intrathecal catheter into the intrathecal space and you've put it in, 3, 4, 5 centimetres. If you pass it quite a way, there's a chance that it can go head caudally down into the sacral segments. And if you're then giving hyperbaric local anaesthetic there, you can imagine that it pulls that high concentration down in the sacral nerves. And so that's what's thought to be why there was these 7 cases. So since then, this is a picture of the microcatheters that they used to use in the early 90s. And so since then, it's been, the technique is much less common in North America. And certainly in my experience as training in 4 different states in Australia, it's a very infrequently used technique. So how does it compare to other techniques? Advantages against a single shot spinal. So duration is the biggest one, that you can prolong it for as long as you need, really. Cardiovascular stability, because you're not giving a big dose at the start, if you can titrate it slowly, it gives the patient time to physiologically adjust to the segmental sympathetic blockade that you've given, and it's much more hemodynamically stable, and you can use it for post-op analgesia. The disadvantage is it takes about 8 minutes to place the catheter, and if you're trying to dose it carefully to avoid hemodynamic changes, it can take anywhere between 20 minutes, half an hour, depending on how worried and how careful you are. Post-dural puncture headache is at least double with an intrathecal catheter, and how much so you'd always consider the risks versus benefits of doing it. Anything else? That's pretty much it for that one. For a combined spinal epidural, so you might just say CSE is a much more familiar technique to me. I'll just stick with that, that's fine. There has been studies looking at one versus the other in Europe. The efficiency is one difference, so it takes about 15 minutes to place a CSE compared to an intrathecal catheter, and the failure rate for when you're using just an epidural for surgical anaesthesia for lower limb orthopaedic procedures is about 9% for an epidural, whereas about 2% for an intrathecal catheter. The other difference between the two of them is that a CSE has been shown to be worse for hemodynamic changes because you're needing to commit to a relatively large volume of local anaesthetic. It tends to spread more cephalad, and so you get a greater degree of sympathetic blockade. What about compared to general anaesthesia? So you might say, it's too hard. We just go with the GA and that's fine. There's been one RCT that's looked at this, and this was in hip fracture patients in Europe. And basically it was a small RCT, so they looked at 15 patients in each group, either with SIVO, with low-dose Remi, propofol with low-dose Remi, or intrathecal catheter, bolused with 0.5 mils at a time, spaced out by 5 minutes of 0.5% plain bupivacaine. And overall, they found that it was much more cardiovascularly stable to use an intrathecal catheter. So you might say, I don't use Remi when I'm 0.1 mic per kilo per minute of Remi when I'm giving my GAs, and that's fine, and that's a valid thing. It might not be valid for you. But in this particular RCT, the dose of ephedrine used in the intrathecal catheter group was on average 3 milligrams compared to the GA groups, which was on average about 30. And you can see from this graph, this is where the maps and the systolic blood pressures for the different techniques, with the CSA being the higher, so representative of the hemodynamic stability of the technique. So that's some reasons why you might want to do it. We've touched a bit on the reasons why you might want to not do it. How do you perform it? If you can put in a spinal and if you can put in an epidural, you can definitely put in an intrathecal catheter. It's not difficult to do. So as per any technique, you'd consent, monitor, make sure you've got adequate access and assistance, get your drugs and equipment ready. Use a full sterile technique. You can do it sitting, with the patient sitting, or lateral. You probably shouldn't be lateral when you perform it. And you just use it as a spinal needle. So you're not trying to do a loss of resistance technique that you normally would with an epidural, because then if you can imagine you're trying to find it with saline, then you dump some saline into the epidural space and then you're advancing the needle. You don't know if it's CSF or saline coming out. So you just use the epidural needle with the stylate in as you would any spinal needle. You advance it until you feel a bit of pops and just check, and when there's CSF coming out, you'll definitely know. Once you're in, you can use a 16 gauge or an 18 gauge. I would always advocate for whatever solution you're going to use to dose it, prime the catheter with that solution so that then when you give a dose, you're not having to think in your mind about what the dead space of the filter and the epidural catheter is, which, by the way, is usually about 0.8 to 1 mil. So that's just some things to consider. Now, 50% of the time, it's a little bit difficult to thread, and that's probably just because the catheter is getting caught on the dura a little bit, so just rotating the needle a little bit can help in those cases. And about 30 to 40% of the time, a patient will get paresthesia. Similar to if you do a spinal, it's possible that they can get paresthesia at the time. There's never been a link between paresthesia during the performance of a neuroaxial technique and neurological sequelae after that. But we would advocate, don't advance the catheter if you're actively getting paresthesia. Just stop, rotate a little bit, or reposition. How far do you thread it? Some consultants at Charlie's thread it up to 20 centimetres. Most studies recommend between 3 to 4 centimetres, and I would probably pick 3 to 4. I think that's reasonable. All of the epidural catheters have 3 holes at the end, the most proximal of which is 1.8 centimetres from the end of the catheter. So as long as you've got all of those holes in the intrathecal space, it's reasonable to do. And how to secure it, just put an IV 3000 over the top. If you're going to run it for pain relief post-operatively, a little bit of surgical glue at the site is useful as well. And I should have said at the start that there's a lot of consultants at Charlie's that have performed this technique much more than me. And I've spoken to all of them at length, and I'd like to thank them for their contribution to this talk because they've got a wealth of experience with using this safely. How to dose it? Most studies just use 0.5% bupivacaine, advocating either for 0.5 ml or 1 ml initially, and then every 8 to 10 minutes, giving another dose. One of the RCTs looked at 5-minute intervals, but they found that they would get at the end of their 1.5 mils or however much they'd put in, they'd have too much Kefalad spread, and you don't need. So basically, if you give it every 5 minutes, you won't have known the full effect of the dose that you've just given. So give it at least 8 to 10 minutes in between boluses. 0.5% plain bupivacaine is not the only thing that you can put down it. Different people put different things like 0.2% ropivacaine, which is works perfectly well for surgical anaesthesia if given intrathecally, and it's probably a bit more hemodynamically stable, but it's less dense, and sometimes they'll be insensate with slight movement. Fentanyl you can add if you want the onset, but in my experience, I haven't used that. It's worked perfectly fine. And for post-operative analgesia, the APS service at Charlie's runs 0.1% ropivacaine at 2 to 4 mils an hour, and definitely contact the APS service before doing that. And that's not the focus of this talk, but if you've got questions, we can potentially have some expertise in the room about that. So what are the pitfalls? Don't use hyperbaric, in my opinion, don't use hyperbaric solutions because of the pooling in the sacral segments. Caution with lignocaine, and definitely don't use high concentration lignocaine for the reasons that I outlined earlier. And one theoretical thing to do is that when you remove the catheter, position the patient in the same way that you would when you inserted it, because that'll stop the catheter from sort of being kinked, although I've never heard of a catheter being kinked off and left intrathecally. That's never actually happened. It's more theoretical. All right, what about experience at Charlie's? So this is a technique that I'd not come across until I was a fellow at Charlie's, and I've worked in lots of different hospitals throughout Australia. I've talked to colleagues from the Northern Territory, South Australia, New South Wales and Victoria, and at most I've heard of this technique only being used a couple sporadic times. But at Charlie's, for the 10 years up to December 2023, it was used 429 times, so about 43 a year. And as you can see, most of the time it's in ASA 3 or 4 patients. 208 of those cases were for hip fracture repair, but also primary and revision arthroplasty have featured a lot, and sarcoma and vascular surgeries as well, and about 10 a year run post-operatively for analgesia on the ward. Speaking to everyone who does these at least relatively frequently, there's been no known complications from those 429 was it cases. There was one 25-year-old with cerebral palsy who had a post-dural puncture headache but didn't require a blood patch. The most common problem is just failure of the technique, either not being able to thread the catheter or for whatever reason it's displaced and doesn't work, which can occasionally happen. And of the 54 epidural blood patches performed at Charlie's in that 10-year period, none of them was associated with a CSA spinal catheter. So it just goes to show that if you're doing it in elderly patients who are comorbid, which is the cohort that we're predominantly doing them in, the rate of post-dural puncture headache is very low. So why is it so uncommon then, given that it has seemingly quite a few upsides? So I think that first of all, it's a rare technique. I've touched a little bit about how rare it seems in my experience in other hospitals. So if you haven't done the technique before, probably you're not going to feel very comfortable to do it, particularly in a comorbid patient who you're already worried about. Perceived time efficiency might be an issue, but I think you just have to weigh that versus the safety profile that you'd get if you use the technique. And the cases that call it for it are complex, so that might be a bit of an intimidating jump to start doing it. And where do I think it fits in? I think ultimately, if a patient's very comorbid, has lots of problems with their airway, respiratory or cardiovascular disease, and you really want to rely on a regional technique that potentially you need to use for a long time, for example, for revision surgery, it can be a really useful and safe technique. And I think particularly in some patients that are morbidly obese that you really want to avoid general anaesthesia, it can also be a good option. Anything else to say? Don't use lignocaine, in my opinion, and just caution / don't use hyperbaric solutions with the technique. I think I'll leave it there. Yeah, and we can have questions at the end, I guess. Very good.
Thanks, Joel. That was great. I know that the spinal catheter has gotten me out of a couple of hairy cases as well. So it's an excellent technique that is definitely underutilised. Our second speaker is Dr. Divya Sharma. Divya is a senior anaesthetist at Charles Gardner Hospital. Other than having a keen regional interest, Divya is also the co-chair of the SIG Wellbeing group, as well as up until very recently running our Charlie's Wellbeing team. So Divya tonight will be talking about ultrasound-guided neuroaxials, and we have a model over here, and she's also created a video, which there should have been a link through that WASORA email that got sent, if any of you guys had a chance of looking at it. If you haven't, Divya will talk you through it tonight, so please welcome Divya.
Thank you. Hi, everyone. So the reason I've developed this technique, and I'd like to actually thank all my consultants at Charlie's and also all the fellows that I've happily had in my theatre over the last couple of years as well to help me develop the video. So I have done hips and knees surgery in morbidly obese patients for a number of years now, and on one Thursday, and the other Thursday I do fractured NOFs. So, and we don't have orderlies, and a morbidly obese patient's feet don't fit on those stools. So having an orderly standing there while you're trying to do this difficult ultrasound, spine, is problematic. And so over the years have developed this technique. So I would call it a real-time assisted spinal, because as we know, the anatomy in those BMI greater than 35, like this is what we get taught, okay? You've got the posterior complex, the anterior complex, you've got the view that you can see with your superior facet joints, your inferior facet joints, the spinous process. And everybody has, you know, I'm not here to sort of really teach you how you are going to find the spinal space, mark it out and all that. I have a personal pet hate for pre-scanning. I think it's the biggest waste of time ever. And so and you just can't see anything or feel anything in these patients. So what is the premise behind? So when you're pre-marking, what you're trying to do really, apart from seeing the superior facet joint and the inferior facet joints, you're trying to find the spot where you see the equal sign, which is the anterior and posterior complex between two spaces, and that's what you're pre-marking when you do a spinal ultrasound pre-mark for your spinal ultrasounds. The aim around using an ultrasound assisted, and I'll call it assisted because you're not aiming to view your needle, is the premise is that in the way that this is developed, you are effectively going to line your probe with the spinous process, and it's going to be a sort of a continuation of the angle of your spinous process on skin with the patient's spinous process, such that if you are parallel to it with enough space to get the hub of your needle in it, so not directly next to it, but probably enough to be able to get the hub of your local needle and the hub of your introducer needle, you will be guided to space effectively. And so the transverse view, as I said, the transverse view allows that alignment with the angle of the spinous process, and the curvy linear probe has a midline marker on it so that that also matches up, and the needle path is parallel to that curvy linear probe. And so I like bright shiny things, and what do we see? So the spinous process has this thickest part of its spinous process on it here. When you get the view in midline of the thickest part of the spinous process, and you can just see lamina with no articular processes, that is when your probe is aligned to the spinous process, such that, as I said, you've got enough space to get the hub of your introducer needle next to it to get into your space. Now the key is positioning here, and it's operative side up with a mattress that's inflated, pillow between the knees. Most patients, and even your fractures, so with my fractured NOF patients, I will do an above ligament fascial Iarca block before moving them onto their side, so that you can still do a non-opiate technique for those patients for their operation. But you've got to bring the leg up and the arm up, and you want this sort of hyperangulation, if you can, of that joint. And often patients that are having the operative side up, they can certainly get the contralateral leg up as well. And so this is the kind of patient that this is what you're practicing for, okay? And you can get it quite nicely, provided that the mattress is nicely inflated, quite well. Here, it's the abdominal fat that doesn't allow that 90 degrees of the hip, but you'll be amazed once you've got the patient in this spot, you can often then, as they are calm and relaxed, bring the legs up even further just before you inject. And the patient's quite stable and comfortable in this position. And now in terms of your positioning and what's going on, this is my pot with saline. So the other thing that I want to say is I do not put gel outside the probe. There is no, it's only saline for contact. I've used this technique enough now that I've actually stopped using gel a lot for lots of things. I just don't like catheters or needles or anything to go through gel. I don't want gel to change the tactile sensation of the back as well, because sometimes you're going to get your fingers back in to have a look. And I don't want gel anywhere near the CSF. So it's saline for contact, which means that you have to actually press quite firmly when you're going to do this, which when you have a patient like this, it's actually easier to do than if you have a patient like that. So it's a 3-step process. So step 1, in those patients, like here, you can see, okay, where the midline might be, but sometimes you can't tell where the midline is. So the fastest way to sort of get you on your way, you're prepped, ready to go. There's gel inside the probe, and in your galley pot, you've got saline, and either you use gauze or you use a little bit of a syringe with saline for contact. You're going to get a transverse view first, just to identify where midline is. And all you are trying to do here is to find both erectospinae muscles and where midline is and line it up. But you don't know which spinous process that is, okay? And so the aim, the next step, is then to go to find out which spinous process you're on, is then to go paramedian or parasagittal. Now, you can go median, but even in an obese patient, your probe will fall paramedian because it's quite hard. And certainly in the thinner patients, going median is a bit painful for them, a bit uncomfortable. Going paramedian is much more stable and comfortable. And the aim around that is then you start counting. Oh, wait. This is it. Then you start counting. Once you've gone paramedian, you start counting. Now, what I find, I know that that L45 space is supposed to be the big space and you can't miss. I have consistently found that space, even with me bringing their legs up, is actually hard to get in the lateral position using this technique, and I'm aiming for the L3-4 space. And so here I'm just counting so that you've got that paramedian view of the lamina. So I call it the running horse, Manoj Carmarker has called it the running horse's head picture of the horses running towards the sacrum. And that's what you're looking for so that you can count. And as I said, it's operative side up. So it really depends on your hands now. So if in this particular patient, we've got the left-sided operation here. I'm right-handed, so then my probe will be on L4 because I'm going to go cranial to L4. Whereas the other way around, my probe will be on L3 and I'll go caudal to L3. And then the third step, and just with this view, you will also be able to tell alignment. So is there any scoliosis? You'll be able to see roughly where your posterior complex is. Technically speaking, you could do a paramedian in plane here. I mean, we do it up higher when we're doing erector spines and stuff like that, but I've yet to do that here. So then once you've figured out which is your spinous process, the next is to basically turn your view back. Now, where are we? 1 second. Yep. Is to turn your view back to. I'm going to turn. So I'm turning on here, and you're wanting to slide to get to the midline first, and then it's a tilting action to get the really nice, bright, shiny tip that I'm talking about, and the widest, brightest, shiniest tip where you can just see spinal lamina and no facet joints means that your alignment is correct. And this is effectively what the view that you're trying to see. That spinous process view and the posterior complex and anterior complex is all very fine, but in a patient like we had this afternoon, this is the only picture you're going to really be able to tell. If you can see the bat ears or the flat, you could probably see the flat of the inferior facet joints. Sometimes it's very hard to see the superior facet joints, and you can only just get a sort of a generalised picture or maybe a look at where the posterior complex is in the patients where this technique really comes into its own. It's got to the stage now, my fellows know I don't let them sit the patient up and I don't let them touch the back. Because they're all very experienced in doing spinals. It's just turning that experience 90 degrees. And this is what I was talking about in terms of going parallel. So you can see here, if I just pause for a second, I'm actually parallel and I'm about, so there's a couple of ways to do that. For those of you that are experienced in spinal ultrasounds, you're always able to do what you normally do with spinal ultrasound, is go in, find where your equal sign is, and then come back and have your probe on the spinous process. So that stops you from having to, mark everything. Or you go probably a couple of millimetres just next to where you can see spinous process glistening at you. And then it's the same with the putting in the marker. So I'll put the marker in, and then what I'll do is I'll put the ultrasound down. So you've basically been assisted to space, and now really your movements are only cranial and caudal. So there's no guessing, you know exactly what space you're in, you know roughly how deep you need to go, and if you need to get the 12 centimetre spinal needle out or not. And so just in terms of the tips and tricks, this is what I was speaking about when we get our model, thanks Paul, in a little bit. This is what I mean. It's either you use saline or you use a bit of gauze with the pot. And positioning, again, where you have a right-handed dominant operator, what I was saying about position for that L3-4 space. And this is what I mean, this tip, so I like the centre probe, and today it was awesome, the new ultrasound machines we got. I got taught voice activation by my fellow, and that was very cool, where I can say centerline off, centerline on, and so that I can see this tip. This is what I'm talking about, where if you're seeing inferior facet joints, that's not good, and if you're seeing one, you're skew-if, effectively. But the other big thing that I would say to you is just before you put the spinal in, this is where, without knowing, your legs would have gone back down. So I always ask the patient or ask my assistant to get them to bring their legs up to just open up that space. So all the things that you would normally do with your patients is what you have to do here. You know, calm, positioning, you know, arching backs, all of that, that all still applies. And now for sitting, it also, we've done this now in thoracic patients as well as sitting patients for spinals as well. So you can do it really quite easily for both. And that's it. I might just get Paul, please, if we can have a quick look. And with the ultrasound machine, yeah. Oh, this bit, oh, maybe we bring that around. Paul, can I just get you facing that? Just bring this around. Can I just have your back facing that? Yeah. No, sorry, your back here. You face that. Okay, let me just. Should we just get you sitting up? Let me just slide down. Yeah, that's fine. So this is kind of what I mean. It's really great that you can, but really you don't want the pelvis to rotate, and so a pillow between the knees is really essential. And again, that pillow and having the patient up here is really good. This is my water glass I prepared earlier. And so, I mean, here it's, you know, pretty easy. Oh, it's going this is going to be a bit cold because I've got a bit of stay on it. Okay. No, this is just, there's no need. The reason the video has no voice is because when the little clip that I had of somebody else's video, he did it completely silent, and I found it very useful to take that in my own headspace, and also very useful to have that where you can just go at your pace and pause and stop without the voice over on top of it. Yeah, this is it. That's all right. So you can see that basically you can get a reasonable view, and we've got some beautiful anatomy here. Again, you know, when we talk about, I'm not here to go through spinal anatomy. I just want to show you the movements that are required. So the first thing you would do is, without even touching the back, you would go and say that this is midline. Okay, and you go, okay, I've got that midline now. I'm going to move. And I like to sort of see it where, so that I know what's going on. So if we want to go midline, this is what, you know, Manoj Carmichael also refers to as the mountain range, you know, the spinous processes. It's actually hard to keep it on there. It's really hard, it's not fun. So going median, parasagittal, you get this running horse's head picture, and every single time, just a little bit more saline as you're going on. There it is, there, that's nice. And in fact, we've got such beautiful anatomy. You can see his posterior, his anterior complexes as well as his posterior. And you can see, that's what I was talking about, that running horse's head towards the sacrum. Further. Okay, so the sacrum's over here. We can see that that's 5. You can see he's got a nice big space actually between L4 and 5 there. And then that's 4. Okay, so remember your paramedian. So if you're going to go back on that, it'll be slightly off centre because you've gone paramedian, and then you bring that back into centre. So now this is what I'm talking about here, where we look at the space between, you start to see, I see the equal sign on here. You start to see his posterior complex. What I'm looking for is up the top, with a slight tilt action, I can see the tip of his spinous process and just lamina, and know that I'll go next. Okay? So that's what it is. Let's just say that. Yeah? Let's just say that. Yeah. Thank you. That's it.
I'd like to have a sip of this water, but I think I'll not do that. No. Thank you, Divya. If anyone wants a copy of Divya's talk, there is the WASORA YouTube channel, and that will be on there, along with a few other videos for interest. So our final speaker is Dr. Steve Miles. Steve is a senior anaesthetist at Charlie's. Steve was also the REO for a long time through ANSCA, and is the resident IT person at Charlie's. Anything IT related he fixes. I must say, when Mitch created this needle, I thought that white thing at the end was just a decoration, just, you know, a bit of a ribbon. But Steve's here to tell us maybe not, and to talk about the utility of nerve stimulators. So convince us otherwise, Steve.
All right, so I'm tempted to drink this.
Oh, yeah. Find it out for you.
Yeah, all right. Good evening. My name is Steve Miles. I'm an anaesthetist at Charles Gardner Hospital. I've been involved with regional anaesthesia pretty much since I went to work there as a fellow. And tonight I'm going to talk about a little bit about the utility of peripheral nerve stimulation. I'm going to talk a little bit about the history of it, about how it works, and perhaps a bit more about how and when to use it. It's been the original description of nerve stimulation was described by Luigi Galvani, who was a professor at the University of Bologna back in the 1780s and was involved in research into animal electricity, as it was known at the time. And he demonstrated that an electric spark applied to the nerve of a dead frog would cause the legs of the frog to twitch. Being a good scientist, he then published his work, and it was, was repeated by another Italian professor, Alessandro Volta, who confirmed that this was in fact actually the case. Volta was the man who named galvanism after Galvani. He gave him the credit for that. He's also the man who, Volta, that is the inventor of the battery that we essentially use inside our nerve stimulator to do this today. The next person who was involved in nerve stimulation is a name that you would be familiar with, I suspect, George Perthes, who was a German surgeon. He's an interesting kind of bloke. He was a student and junior doctor with a Professor von Trellenberg, whose name you would recognise. As was the case, I think, back in those days, the opportunity to do lots of different things and dabble in lots of different areas was quite large. He described management of empyema with a chest drain, which was new. He was the first person to x-ray the bound feet of Chinese women and to show what the deformity was. He was also gave an early description of radiotherapy for breast cancer. And obviously, his eponymous disease, he described avascular necrosis of the hip in children. However, the bit we're interested in was he developed a machine to deliver electrical current to assist in nerve location for regional anaesthesia. At the time that he was operating, you had the choice of ether or chloroform, which were both had significant side effects and were not particularly safe. So regional anaesthesia, which had started to come in at the start of the 20th century, was considered to be much safer. At that time, nerve location often involved the surgeon dissecting down to the nerve and then injecting cocaine into the nerve or perhaps procaine into the nerve under direct vision. And Perth felt that this was that there would be a better way of doing it. So he developed a machine which was able to deliver a current. He had a foot switch to turn the current on and off. He used a nickel metal needle with a syringe on the end of it with procaine, a wire to his machine, and had the needle varnished right to the tip of the needle so that it was insulated, and described a series of 22 patients where they were pre-medded with a medication called panopticon, which was a bunch of opiates, and scopolamine to pre-med them, and then blocked them with procaine 3%, and was able to do a variety of surgeries. Mostly there's some sarcomas, but all peripheral limb operations. Then the next thing that we come across is the introduction or rediscovery of the advantage of insulated needles. There does seem to be quite a long period where nerve stimulation disappeared and nobody was particularly aware of it. The next 10 years later or so, the introduction of modern solid-state electronics allowed better nerve stimulators to be developed. In the 80s, there was more evidence of the advantages of this. And then in the 1990s, nerve stimulation appears to have become a well-recognized and accepted technique for regional anesthesia. Certainly, when I became involved in regional anesthesia at the end of the 1990s, I was taught by various of my colleagues at Charlie's, and it was normal practice to use a nerve stimulator for most of the blocks that were available at that time. Obviously, ultrasound was not an option at that point, and some of the blocks that we do now with ultrasound were not used at that time. Then, in the early to mid-2000s, ultrasound began to appear, and that appears to have gradually displaced nerve stimulation. Obviously, there are blocks with ultrasound that were new and techniques where people were able to be successful without nerve stimulation. So this is just a definition of what we're doing. So electrical nerve stimulation with low intensity and short duration electrical stimulus to produce a defined response, which is a muscle twitch or occasionally a paresthesia, to locate your nerve to inject your local anesthetic. With the use of nerve stimulation, you can help to confirm that a structure you can see on ultrasound is a nerve. You can improve your ability to place the needle tip close to the nerve, or be sure that you are close to the nerve. You can recognize intraneural placement of the nerve if you're getting nerve stimulation at extremely low currents. And in doing so, prevent further needle advancement and reduce the risk of injury. And you can still locate nerves without ultrasound. So a little bit of the electrophysiology. You need a stimulus of sufficient strength and duration to depolarize the neural membrane, and then when you get depolarization, obviously you then get muscle contraction. So there are a couple of terms which, if you've read a little bit about nerve stimulation, you may have come across. So the minimum current required to cause depolarization is called the real base. So on our diagram here, this current, the lower dotted line is the real base. So you can see the duration of that is quite long. When you go to 2 times real base, the current duration time is significantly shortened. And this is for a motor nerve. Below that level of current, you will not get an impulse, even if you keep that current running for a long period of time. The chronaxy is the length of time that the current must be applied to the nerve to initiate the stimulus when the current level is twice the real base. Now, that's all sounds a bit sort of gobbledygook, but essentially, with the red line here, which is motor fiber, at short durations, you need relatively small current. To stimulate a sensory nerve, you need long duration and at that current. So 1 millisecond versus 0.5 to 1 millisecond. And that's what allows nerve stimulators to produce a motor stimulus without causing, generally without causing paresthesia or pain. The chronaxy describes the different excitabilities of those nerves. Yeah. You will find in some patients that you get some stimulation of sensory fibers, and patients will report a paresthesia that is intermittent in time with the stimulation, rather than a direct contact paresthesia. So using the nerve stimulator, we've got the yellow adjunct nerve stimulator is what what we've used for the last sort of 15 to 20 years at Charlie's. The StimPod nerve stimulators here, if you've worked at Hollywood or Bethesda, you would be familiar with those. I'm not sure what people might use elsewhere, although they can be hard to find. At Charlie's, we have, I think, 2 of these left to service 15 theatres. But using nerve stimulators, you want a nerve stimulator that's specifically designed for nerve stimulation. It should be a constant current generator. What that means is the resistance, or more accurately, impedance of the tissues and the nerve, the needle, can be quite variable between different patients, and a constant current generator nerve stimulator will maintain a constant current despite variations in those. You should be able to vary your pulse duration. Typically, we would start at 0.1 millisecond. Also, you should be able to vary the frequency. Generally, you would use 2 hertz. When you go to higher frequencies, it tends to be more uncomfortable for patients. It should display the current setting and the delivered current, so that you can tell that it's doing what you're asking it to do. And ideally, it should have an auditory signal so that you can hear the frequency of the stimulation and also the current intensity. So with the Padjunk and the StimPod, as the current reduces, the pitch of the tone starts to increase. So you can tell while your assistant is changing it that they're doing roughly what you've asked them to do. When to use it? Well, these days, almost all nerve blocks with nerve stimulation it's used as an adjunct to ultrasound-guided nerve block. So, as I said before, you can help to confirm that the structure that you think is the nerve is the correct structure. It may help you to identify the tip of the needle because of the twitches occurring, can identify intraneural placement. You can also use nerve stimulation alone if you have no ultrasound available. With very large patients, my personal practice is probably not to even bother with an ultrasound because I find that they're so, the view is so deep and the quality of the pictures that you get are so poor that it doesn't really help. You can see this patient here, we're doing a Labatt nerve block in his left buttock, and that's a 120 centimeter needle, of which there's less than 1 centimeter on view. He had a very big backside. But we were able to successfully produce a block which provided him with good postoperative analgesia. How to use the nerve stimulator. So in the first of all, you attach an ECG dot to the patient's skin. If you're being fastidious about it, you should clean the skin with an alka wipe, dry it, and then put the ECG on. Best on skin that hasn't seen sunlight and isn't, because it is usually you get a good contact with it. You attach the cathode to the needle. All of the nerve stimulators that you'll use now, you don't have to worry about which color you're attaching because of the way they're set up. Set your frequency to 2 hertz, current duration to 0.1 milliseconds, and the current to 1 milliamp, and then insert and advance towards your target. When the twitches occur, gradually reduce your current to about 0.3 milliamps. Usually by this time you can see that your nerve, the needle tip is pretty close to the nerve. When you're unsure whether it's a nerve, if you haven't got, you won't have got as far as turning it down that far until you contact the structure. And if it's then you're you get the twitches when you contact it, then you want to turn down to 0.3. If you still get twitches at 0.3, you are potentially inside the structure of the nerve, at which point you should withdraw your needle. When you inject 1 to 2 mils of local anesthetic, when your needle position is where you want it, the twitching should cease. And then at that point, you can inject the rest of your local anesthetic. So these are just some general tips for using a nerve stimulator. Use sedation for awake patients because it just makes it more comfortable for them. You let your patient know what to expect, that they will feel muscle movement, muscle twitching. It's an odd sensation, but it's not painful. And also, if you let them know that they may get some, like an electric shock, so essentially a paresthesia, if they do get that, they will report it to you. Often if they don't, and saying to the patient, if you can feel twitches, please tell me, because sometimes they're subtle and you might not notice them immediately. With older or frailer patients, I would normally start with a current duration turned up to 0.3 milliamps and often put the current up to 1.5, because I find that old nerves require a larger kick, as it were, to get a stimulus. The other thing that's really important to be aware of, and I can certainly remember the first time I saw this with ultrasound, is that being in contact with the nerve may not elicit a twitch. There are several reasons why that might be. Most commonly, it's because you're sitting up against a piece of nerve where it's fairly well insulated, and the stimulus that you've got is not enough to stimulate the nerve. You find often if you withdraw your needle and replace it on a different part of the nerve that you will then get an expected twitch. You may realize at that point that your patient's paralyzed. That's been done a number of times. Or you may realize that the sound that was coming from the nerve stimulator is not coming from it anymore, and you may have a disconnected circuit or an inadequate contact with the ECG dot. When not to use it. I don't think it's really compatible with harder dissection techniques. If you use 5% dextrose, rather, that doesn't diffuse the current, but local anaesthetic has saline in it, and that diffuses current quite efficiently, so you're unlikely to get any nerve stimulation if you're hydrodissecting with your local anaesthetic. It doesn't work in paralysed patients. With patients who are in quite a bit of discomfort or with fractures, you probably shouldn't use it while they're awake. It's fine to use when they're asleep. And this is just a quick video of a block that we did a few weeks ago. This is a Labatt approach for a sciatic nerve block in the buttock. And in fact, it has a reasonably visible nerve, although slightly odd, a bit flatter than I would expected it to be. But you can see this is what we set the nerve stimulator up at, and this is what happened when we get that. You can hear the high-pitched twitch in the background, which is the auditory signal. Whoops. And that's it. I'll let...
Thanks, Steve. I think I'll stop pulling the white thing off the needle now and start using it. We'll have a Q&A session now. Just get some chairs up and some roaming microphones.
You have to pass it around. Here's one. You guys can just share it for whoever has the talks. Do we have any questions from anyone? Someone want to start the ball rolling? I feel like I'm an auctioneer.
Mitch.
Thanks for all the talks. Joel, just particularly about the spinal anaesthesia. From your experience, what's a typical dose that you've had to give, and what sort of duration do those low doses tend to give you for your surgery?
There's probably other people in this room who've done it much more frequently than I have, but you can get away with much lower doses, and so you can do a neck of femur fracture on just 1 ml of 0.5% bupivacaine. And the reason you can do that is because you know that you don't need to overshoot for a longer duration. You only need to get right to the segmental level that you need for sensory blockade. And then if at any point they're starting to move or feel anything, you just give another dose and it's very reliable. I think the lowest amount using 0.2% ropivacaine has been like I think we used, when you convert it, about the equivalent of 0.8 mils of 0.5% bupivacaine using just 2%, 2 milligrams per mil, so 0.2% ropivacaine. So I think we used that and bolused, I think 4 mils, something like that.
And that was going to be my follow-up question. With the ropivacaine using 0.2%, what's the first dose you give?
Just 1 mil at a time. You could even go 2 mils initially, and then just 1 mil every 5 minutes or so. If you're using bupivacaine, just give it 8 to 10 minutes between intervals.
Hi, thank you. Just another question for John. When you're topping up the catheter intraoperatively, do you find there's an expected duration at which you need to top it up? And is there any decreasing efficacy of the dose that you've found? Because in my former institution, we'd use them for epidurals quite often when you've had an inadvertent dural puncture. And they seem to become less and less efficacious through labour. And I wonder if that translated all to the surgical environment.
I couldn't quite hear all of the question. I gathered that you wanted to know how frequently you need to redose it. I think probably every half hour, 45 minutes, you might need to give a little bit more, but it depends on what you gave initially. Because if you give a bigger initial dose, and particularly if they're hemodynamically stable, and you might push it a bit high, because you think they're coping well, you may not need to top it up again. Whereas if you're trying to get a really low dose, then probably something like every half hour or 40 minutes would be somewhere about right.
And sorry, the second part of the question was, did you notice if there's any decreasing efficacy in your top-ups in terms of the dosing you're needing to give escalating?
No. One thing to say is that I have used it once for an obstetric top-up, which was an accidental dural puncture intrathecal catheter, and we were using heavy bupivacaine. And so again, it's probably needing a higher dose because it's heavy and you dose it and it all sinks down the sacral segments, particularly if your catheter has thread cordad, because then you're going to need the higher doses to get it moving cephalad. So it's a different situation because you're using heavy. Whereas in orthopedic surgery, which is when I've used it most, just using plain, you don't have to worry about where the catheter is. Enough dose, it'll get up there, and you don't have to worry about it spreading too high because you're using heavy and high doses.
So a question for Joel. Do you recommend any particular size gauge TUI to get access to the IT space? Or?
Yeah. So a lot of the consultants at Charlie's will use 16 gauges. Some will use 18 gauges. I think if you're, the rationale for using a smaller gauge would be lower risk of post-dural puncture headache, but I think once you've punctured the dura with a TUI of any sort, you're probably going to run that risk at least to some degree. The advantage of a 16 gauge is that you really get good feedback that CSF is coming back. With the 18 gauge, if you're trying to sort of aspirate on the filter needle, you do get CSF coming back, but it's not quite as obvious. Whereas with that's with the 18 gauge, but with the 16 gauge, it'll come back like really easily. So you can be definitely sure that you're still intrathecal. So that would... Yeah.
It's pretty obvious if you do loss of resistance to air, if you've got air in your syringe.
Yeah, you can use loss of resistance to air. I think that would be okay. But you're not trying to delicately find the epidural space.
No, but just for practice.
What's that, sorry?
It's just for practice because I don't do many epidurals. So anytime I get a chance to do an epidural.
There you go.
Joel, do you find sometimes that in the lateral position in the elderly that it's quite a low CSF pressure, and it's almost sometimes you're relying on tactile feedback, and that sort of obstetric CSF gush isn't as evident?
Definitely. So that's one of the reasons why elderly patients don't tend to get the same dural puncture headache, is because they don't get the same leakage of CSF through that dural puncture into the epidural space. And you definitely don't see, you'll still see drops. I've not yet had one where nothing came back. I've had that with spinal needles, but not with an epidural TUI needle. I don't know if anyone else in the room has come across that before. I know one of the consultants has had that situation where he could see, he's a pain specialist, and he was putting it in under CT vision, and he still didn't get any CSF come back, and he expanded the space with saline. So it definitely can happen. Hasn't happened to me yet.
No.
everywhere, every time.
You use everyone
Every time.
And,
In fact, I almost didn't know what to do with him sitting.
did you notice a change in the success rate or the speed? Or
Well, I know, so success rate, although today, this afternoon's patient put paid to that. My success rate and my confidence level in, so I know exactly where I am, is higher. We've used it quite well with the thoracic epidural, thoracic epidural. We did it a while ago overnight. I think it's still faster. By the time, you don't have this patient, doing this, foot coming off, all that sort of rubbish. And also, it's more efficient with operative side up. They can go back onto their back. You can do the adductor canal quite quickly rather than sitting them up, palaver, fat person, and sitting them back down, and lying them back down. So it is a bit of a mind bend when I teach, but it doesn't increase your time because you think your fingers are fast, but in a fat person they're slow. And so you have to think of the ultrasound as a way that is more accurate than your fingers. It increases my confidence to go in that space and try in that space. And then I will say, even if I've done all the repositioning, I will then go up to the next level. But I know exactly where I am, and I can often, if I'm not sure and I've got the spinal needle in, I'll bring the ultrasound back and see where am I again. Is it next to where I think the midline is, or have I now just sort of trapped medial lateral instead of cranial or caudal? So for me, it's been something that just makes sure exactly where I am. And as I said, I know that everyone says that L4-5, it's a wide open space, and you can often see that, especially when you do the paramedian approach, but it just doesn't open up as much for me with the ultrasound technique laterally. I have much more success at L3-4. So, and often it's easier to teach with good sonoanatomy. And so it's nice, like today when we had our patients from BMI 27, 35, 45 during the day to get to that. And because the fellows have so much experience, if they're having difficulty with me teaching them, me taking over from them doesn't necessarily, after we've done a couple, doesn't necessarily mean that I will be any more accurate than them, because once it's clicked that it's where their mental picture is, their skills are there to do what they would normally be doing and have been doing for so long. The other thing that I wanted to just say around the spinal catheter thing, you have to understand at Charlie's, we've got patients that are like rock in a hard place. And a spinal catheter is an easier decision than when they're that old.
They're also very gentle compared with using, a single shot. Prior, when I was a registrar at Royal Perth in the sort of, mid-90s, access to echocardiography was daytime only, and even then difficult. So quite a lot of patients for NOFs were done with spinal catheters, because then you could titrate and get a slow onset block for patients who you think, I can hear what sounds like an aortic stenosis murmur, but I can't get any confirmation of how bad or otherwise it is. And it was a very nice technique for that. And then the cardiologists got better at providing the service.
Ryan.
My question is to Steve. I guess I stopped using nerve stimulation a long time ago because I felt it difficult to handle the poor negative predictive value of the nerve stimulation. How do you practically handle that with your teaching when you can see that on the ultrasound that the difference is where you want it to be, but there is no switches? What do you do in that circumstance?
In that situation, if when I'm teaching a reasonable number of blocks, we'll use a nerve stimulator, not because we particularly need it, but just to familiarize yourself with it. And you will identify a nerve, you have almost no doubt in your mind that that's what it is, and you will get a needle onto it, and it doesn't cause any twitching. Normally I would try moving it a little. If it doesn't at that point, that's fine. You ignore it, you do the block, you go and see your patient afterwards, you confirm that you got the block you expected to. From a teaching point of view, I find it more useful for the situation where you've got a terrible view. You have a good idea of roughly where the nerve might be. You've scanned up and down and you think this is the correct structure. But when you're bringing the needle through, even with the Stimulplex needles that we use all the time, you can't easily see where the tip of the needle is. And if your trainee is, let's say, struggling to an extent to keep the tip in view, that appearance of twitches, when you didn't realize your needle tip was there, is A, you've identified the nerve so you know, B, you're not skewering it, although clearly from your comment, in a proportion of those patients, you will get a needle into the nerve before and a reasonable distance in before you get twitches. But that was going to happen anyway without the nerve stimulator. So it should happen less frequently with a nerve stimulator. It doesn't guarantee, but it definitely helps, I think, in that situation. And where you have a structure that most of the time, when you can see it and you know it's the nerve and you bring a needle to it, you will get twitches.
Are you using it most of the time?
If I was only allowed to use it for one block, it would be sciatic nerve blocks, definitely. Because they tend to be deep and not straightforward.
It's a high sciatic nerve block, is it?
Yeah,
Not,
I do not do sciatic nerve blocks below mid-thigh because the complications rates for the lower down are much higher. And because of the I do a reasonable amount of sarcoma work, so we do end up with quite a lot of patients with tumours up high up the back of their leg where you need to do a Labat or even occasionally a parasacral approach in people who Divya would be using her ultrasound to do their spinal.
yes, question at the back.
Hi guys, this question is for Joel specifically. Just could you speak a bit about blood thinners and patients on anticoagulation? A lot of these NOF patients obviously are on blood thinners. So have you read anything in the literature or anecdotally at Charlie's in terms of what, say, platelet count, INR, or like factor 10A levels that you'd be comfortable doing a CSA technique in?
So I think there's never been a epidural hematoma or spinal hematoma from a CSA intrathecal catheter technique. But I think just like any other neuraxial procedure, just follow the same that you would for a spinal, for an epidural, all the same rules. I just play it the same way as when you're removing the catheter as you would play for anticoagulation for removal of an epidural catheter. It's probably going to have a lower rate of epidural hematoma than an epidural catheter would, because if you can imagine the epidural catheter is going around the space where the actual blood vessels are, so retraction of that catheter is more likely to traumatize them. But I'd just follow the same rules.
Thank you.
Question for Steve. How do you think the learning curve for peripheral nerve stimulation compares to ultrasound for learning? Is that better? Yeah. How do you think the learning curve for peripheral nerve stimulation compares to ultrasound for learning regional anaesthesia?
Well, I think if you do both, you probably learn at roughly the same speed. If you're using a nerve stimulator alone for nerve blocks, then you need to learn the landmarks well, and that's it's probably less straightforward than certainly learning with ultrasound. But because ultrasound is available and is, you would say gold standard for nerve blocks, it's straightforward to teach it along as part of an ultrasound technique. Learning or doing blocks in morbidly obese patients is hard, or can be very hard, whichever way you do it. So you need to understand the anatomy, you need to get the best picture you can, and the neurostimulator, I believe, adds a degree of safety and probably improves your likelihood of achieving an effective block in the more technically challenging blocks. But if you practiced it in the straightforward ones, so that you are familiar with how to use it, and you've seen it work and you know what to look for, when you find yourself in a situation with a difficult patient, all you have to think about is, where am I getting my needle to? You don't have to worry about the other bits and pieces. So if you're trying to use a neurostimulator for the first time because you can't see anything in a patient who's a BMI of 40, you've got so many things you're trying to do at once, it's hard. If you have used it reasonably frequently and understand how to set the machine up, what the potential pitfalls are, then when you use it in a difficult patient, you don't have to think about the rest of that.
Just on that note, do you think it should form part of mandatory training for regional anaesthesia trainees?
No, I don't. But I think it's something that if you want to get the best service to your patients, I think it is a useful part of regional anaesthesia that currently is probably underutilised.
Some other questions before we wrap it up? No? All right, guys, I'd like to thank our speakers. Just something small to say thank you. Thank you very much. Thank you all for coming. Please come again in 6 months' time. And if anyone has any ideas or wants to give a talk themselves, please come and approach me at the end. Feel free to stick around and have a drink or some food. Otherwise, have a good evening and we'll see you soon.